Thank you all for coming to Cancer Center Grand Rounds. We have really two superb talks that I think address two very important areas, both in medicine and cancer care and cancer research. And so we'll turn first to our first speaker. Cary is a professor of medicine and public health. He founded the Cancer Outcomes Public Policy and Effectiveness Research Center, or COPPER, which is as well as the director of the National Clinician Scholars Program. And as you all know, COPPER really has been a national and international leader in health services research, really addressing fundamental questions, I think, in cancer care policy and how we bring improved quality and value-based care within our world. Cary had completed his residency at New York Hospital Cornell Medical Center, served as chief medical resident at Memorial Sloan Kettering the following year, and he's going to talk to us about something that I have not previously heard him speak about, which is conflict of interest.
Thank you. Thank you for the invite, and thank you all for joining me today. Let me get organized here. So I was saying to Charlie, I used to give talks about financial conflicts of interest regularly. This is something that was and is a passion of mine. And over the past few years, it's become apparent to me that I think I should get back in the game, because I'm a little concerned about where we're headed with regard to financial ties, and I think it would be interesting to talk about. And I would love to have this conversation. So first, well, it's appropriate to start with my own financial disclosures. And what do we mean by financial conflicts of interest while we're talking about this? The AAMC has a definition, which is an old one, but it's a very reasonable one. Situations in which financial considerations may compromise or have the appearance of compromising an investigator's judgment in conducting or reporting research. Note that nowhere on here does it say potential conflicts of interest. So one of my goals for today is if we could abolish potential conflicts from your lexicon, because financial conflicts are dichotomous. They either exist or they don't exist. Here's an analogy. A dog is either alive or he's dead. Same thing with the financial tie. It's there or it's not. So please, let's drop potential conflicts. So while I'm on the subject, the agenda for today. First, why are we now, or I should say still, talking about financial ties? Haven't we addressed this already? Second, I plan to review some new evidence linking financial ties to clinical care and, more importantly, more directly to clinical research. And then review some new approaches and partnerships that have been undertaken by some colleagues here at Yale, including Jen Miller, who's nice enough to join us in the room. So why focus on financial ties now? One of the main concerns is that healthcare spending in the United States continues to increase dramatically. It might be hard to see the y-axis here, but we're now over $3 trillion per year in total healthcare spending. Percent of GDP here is now about 18%. And yes, financial ties and financial conflicts are contributing to this increase in healthcare costs. Nowhere is this more directly relevant than in cancer. The average median cost of a new cancer drug is over $10,000 per month. This is a nice slide that Peter Bach's group put together out of Sloan Kettering. These increased costs of medications are directly affecting our patients with cancer. It's causing increased risk of bankruptcy, causing decreased access to care, exacerbating long-standing racial and socioeconomic disparities. So these healthcare costs are having a direct effect on our patients. Now let's move on to marketing. I recently have been searching for how much variety of stakeholders are spending on marketing in the US. McDonald's spends about $700 million per year in marketing. Budweiser, $1 billion. The whole beer industry overall spends about $3 or $4 billion from what I can pull together. How much does healthcare spend on marketing now in the United States? It's increased over the past 20 years from almost 17 to about $30 billion per year we're spending on marketing to get more people to use more healthcare, usually more expensive healthcare. On the right side, you'll see the marketing to healthcare professionals has increased to about over $20 billion per year. A lot of this includes direct industry payments to physicians and hospitals. This is a summary of the open payments database. Just look at the blue line on the bottom. So there's about $3 billion per year that are in general payments from industry to individual physicians. And this is not research-related payments. These are like meals, speaking bureau, textbooks, or whatnot. The strange thing is this adds up to over 10 million payments annually. The reason why there's so many payments is that a lot of these transactions are really small amounts, like $10 here, $12 there. So it's a pervasive, small, and persistent. So next, another reason for concern is the landscape of medical research has been changing dramatically over the past 20 years. Not only is more money being devoted to research, which is a good thing, it's increased from about 60 to well over $100 billion per year. But I'm sorry, there's so many different colors here, but just focus on the green. Those are the industry sponsored research domains. So that increased from about 25 to well over 60 billion. But the important thing is that the proportion of the overall research spend that's coming from industry has increased from 42 to about 65%. And at the same time that's happening, the actual NCI funding has been stagnant for the past 20 years. So just look at the purple lines here. I think this room is very familiar with this. There's really been no legitimate increase in NCI funding for the past 10 years. Challenge is that as more and more people are submitting grants in this stagnant funding, the grant funding rate has declined substantially. So as a result, we have more research being funded by industry, but also a lower likelihood of getting your grants funded when you're looking to non-industry sources. This results in more investigators turning to industry for a source of funding. And industry, just to be clear, need not and should not be demonized in any way. However, it's important to note that the type of research that industry funds is different. Industry has a fiduciary responsibility to their stakeholders, or I should say to their shareholders, to make a profit. That's why they exist. They need to ensure that they are conducting ethical research, but they also need to bring new drugs to market. Over the past 10 years, there's been an increased use in the way drugs are being brought to market. So the FDA has this accelerated approval program, which is used for life-threatening conditions. Surrogate outcomes are encouraged if they are reasonably likely to correlate with health outcomes. And but this represents a trade-off because you're allowing for quicker drugs to come to market more quickly, but you're requiring post-approval studies. So it's a speedy to market, but we're saying you have to make sure you study this after the new drug becomes available. However, 5 years after FDA approval, the evidence is often lacking. Not all of these post-marketing drugs are being done. So in Europe, of the 68 cancer drugs approved in a 4-year period, half of them had no supporting evidence guiding survival, I should say, regarding survival or quality of life initially. And after 5 years, the majority still had no data regarding survival or quality of life. Similarly, FDA approval, just to move on, is a similar story. A lot of the accelerated approvals are not being followed up with studies with a hard outcome. This is just to make the point that, again, the type of studies that are being funded by industry are different than those that might be funded by a different stakeholder, someone who might just solely be worried about comparative studies, or does a drug or approach improve quality of life or survival. At the same, forgot, don't look at this yet, about 40% of new cancer drugs that are approved on the basis of only a single study. And that's a concern because, okay, now look at this, because there's been a recent phenomenon in the field of science that we need to think about reproducibility. So here, this was really a high-profile article in Science where, this is in psychology, this is not the cancer research world, but they found only 39% of studies in the psychology field could be replicated. They then, in Nature, they surveyed scientists in a more broad collection of specialties and areas of focus, and they found that about half of them agreed there was a reproducibility crisis. Amgen, I don't know if you're familiar with this, Amgen has this had an internal program where they tried to replicate some basic science experiments in the field of cancer, and they found many of these basic science studies couldn't be replicated. So, and in this survey, more than half had tried to and failed to replicate results. So at the same time, there's a concern about this reproducibility crisis. But on the other hand, we're approving drugs based on a single study and not following it up. So even if the first study is really strong, it's possible that it might not be reproducible. So, okay. So next, probably the most concerning recent phenomenon from my perspective has been this increased concern about why are we focusing on financial conflicts. There was a very high profile trilogy of articles in the New England Journal basically making the case that we are focusing too much on financial ties when we're not sure that these ties are harmful to science, not sure that they're harmful to patients and or to the healthcare system. And the bottom, this is the New York Times piece talking about why are we focusing on financial ties when there are many other types of biases that can affect science that are really important ones. So let's first talk about evidence. I'll put a pin in this idea of the evidence regarding financial ties and how that might affect science and scientists. We'll come back to that. But with regard to this balance between financial ties and other forms of bias, yes, it's absolutely important to acknowledge that there are other critical forms of bias, whether they are your political agendas, religious beliefs, desire to prove your prior hypothesis, desire for funding. These are critical biases, they're hard to measure, and they can absolutely affect our science. However, financial ties are also important. They are, there's a well-known and well-documented association between financial incentives and human behavior. People are motivated by money. I'm sorry. Also, financial ties can be quantified. They can be easily understood by the public. And there is actually a strong evidence base to support them, to support the fact that they are affecting all of us, be us, be we, clinicians, scientists, or anybody. So with regard to this question of why focus on financial ties when there are other threats out there, when there are other things that we could be worrying about. Let's bring a Game of Thrones reference. You could make the same argument, why worry about this is one villain from the show Game of Thrones. Why worry about this guy if there are other things we can be worried about? It doesn't really make sense, because just because there are other bad guys out there doesn't mean you ignore this one, right? Again, I'm not saying that the financial ties are the Night King, but the point is, it's a complex world. We can and should worry about more than one thing at a time. So that's the final concern, the final motivation, skepticism about financial ties. Fortunately, we now have a stronger evidence base than we ever have before. We have new partners and new approaches that can help us to think about how to manage these financial ties. So one thing that's been helpful is this open payments database where there's a very clear requirement as part of the Affordable Care Act for documenting all industry gifts to clinicians. That's been mined like crazy. There's probably like 50 papers that people have been going bananas with this database. So we already said that 65% of research roughly is funded by industry. So we now know that FDA employees on advisory committees, Vinay Prasad did a very nice study where even though these employees are not allowed to have a financial tie, they're working for the FDA, 40% of them went on to go work for industry, specifically for the company that was, whose products they were regulating and making decisions about. Other studies have found that 25% of public speakers at FDA advisory committee meetings actually had an industry tie, and the majority were not disclosed. I'm not going to beat a dead horse, but like journal editors, guideline authors, there's new oncology clinical pathways. Many of their board members have financial ties. Oncologists, one study found about 2/3 of oncologists have received these general payments, non-research. Again, the mean is 11 payments per doctor, $600. So mostly these are very high frequency, but very, very small, small amounts. And this was, I don't know if you saw, Zeke Emanuel had a nice piece in JAMA just a few months ago talking about patient advocacy groups, and the majority of them have industry funding. Or 30% of these patient advocacy groups actually had an industry executive on their board. So my concern about all this is that industry ties have become so pervasive that we may not even recognize them anymore, like the old joke here. So briefly, I just want to touch a little bit on the, specifically on the oncologists. Financial ties, we could talk about clinical care. So Scott Huntington led a really nice analysis of physician ownership of PET scans with the idea of looking at different types of lymphoma. The top one, this is the one for which PET scans are recommended. Then CLL PET scans are not recommended. And then here's one where it's equivocal. It's not clear whether there's a recommendation for, the evidence is neither for nor against. So the question was, and then you could see some of these patients were treated by doctors who owned PET scans, some of them by non-owning doctors. And what Scott found was that basically among the patients who are supposed to get a PET scan, if you own the PET scan, it's a blue bar, you're a little bit more likely to get the PET scan. Among patients with CLL, these are patients who are not supposed to get a PET scan. If you're treated by a PET scan owning doc, you're substantially more likely to have a PET scan. And same thing for the equivocal, it's even a stronger relation. So the idea here, this is a really nice example of how the impact of financial ties varies across your clinical indication. Just to move on, same thing was found for receipt of payments from industry. This is the open payments data. The gray bars, the docs who receive payments are more likely to receive these certain specific drugs about which the payments were made. And the idea here is, again, getting back to the New England Journal series where they talked about, is there harm to patients? Like, why worry about financial conflicts if we don't know if it's really harming? What I would say is if you think that unnecessary PET scans are harmful, and I do, then that's evidence of harm. If you think that your choice of which cancer treatment you get being affected by a financial tie can be harmful, then yeah, that's a harm. But let's turn it up a notch. So let's go down over to the issue of opioids. I think most of us would agree that this is a really dangerous drug, opiates in general. So led by one of our clinician scholars, Will Fleischman, he looked at opioid-related open payments data and specifically the receipt of opiates at these high doses, higher than 50 or higher than 90 morphine milligram equivalents a day. These are the doses that the CDC says to be careful. And what Will found was that the docs, well, first of all, it's kind of crazy. 141 million prescriptions for opioids. This is the national Medicare data he had access to. 45% of beneficiaries received at least one opiate. It's crazy, but that's why we have this problem. 23% had a moderately high dose, 7% had a very high dose. And for both of these, there's a strong relation to industry ties and receipt of a very high dose. I'm going to skip over the FDA. So let's go a little bit more to look at the mechanism underlying this relation between financial ties in research. So in the past, there's been concerns about publication bias. A nice piece by Joe Ross here showed that, and team, showed that even 5 years after a study is completed, only about 60% of results were published. This is a analysis of the SSRI randomized trials in children, which came out, this is came out as a result of New York State Attorney General a legal action against GlaxoSmithKline. The industry side here, well, this is what the published literature showed. So the industry-sponsored study, there were very few negative trials and a lot of positive trials. However, after the discovery process, when unpublished trials were identified, this is what the actual body of literature looks like. So just think of how this affects meta-analysis, clinical guidelines, et cetera. Fortunately, these kinds of misbehaviors, if you will, led to, literally, to acts of Congress. This led to medical journals requiring that studies be registered. And now Congress requires, through the Food and Drug Administration Authorization Act and Renewal Acts, that studies have their results published and disseminated online. I'm going to skip over this, actually. So if we put a variety of these factors together, in summary, what does the aggregate odds of an industry-sponsored study finding a pro-industry result come out to? This is a meta-analysis we conducted some time ago. We found that industry-sponsored studies had 3.6 times the odds of a pro-industry or positive outcome than non-industry sponsored studies. And then here's a more recent analysis. Actually, it's interesting, the odds are almost exactly the same. When the principal investigator had an industry tie compared to non-PI. Here's a similar study looking at cost effectiveness studies. Shi Wang has done a really nice systematic review. This was recently published in the JCO, looking at Oncotype DX, looking at cost effectiveness analysis, because increasingly we're turning to these cost effectiveness analysis to help us make decisions about coverage and access. So what Shi did is he found all of the economic evaluations of Oncotype DX. And first of all, he found 27 of them. How many cost effectiveness analysis does one need? It's a bit much. And then 15 of these were sponsored by industry. And the concern I have was, first and foremost, is are we just kind of spitting out these analyses at a very high rate? And why are we doing that? She found that, this might be hard to see. So the y-axis is actually incremental cost effectiveness ratio. So the higher you go, the worse it is. So it's less cost effective. So if you look at the industry funded studies, the blue ones, which are the blue ones, they tend to be lower than the yellow ones. And he found that all studies reporting that the intervention was cost saving were funded by industry. The 2 studies which found that it was not cost effective were not funded by industry. So summary for here is that these financial ties are pervasive, powerful, clinically hazardous, and a threat to scientific integrity. I'm gonna have to burn through this pretty quickly. So disclosure, we've done several studies looking at disclosure. It's not the answer because a lot of patients don't understand it. A lot of, in fact, may even misunderstand the information that's disclosed. So there's also approaches to manage and restrict financial ties, which are really important. So professional societies such as ASCO is really taking a lead in many respects with regard to restricting financial conflicts in certain areas. Governmental agencies, I mentioned Congress making us disclose financial ties, ensuring that we're disseminating results. For clinicians, I would argue there's really no reason to take these general payments. The average oncologist is getting 11, and it's adding up to $600. I looked it up. The typical oncologist in the United States makes over $300,000 a year. You don't need the $9 lunch. That's not saying don't interact with industry for research. It's very different. We need our industry collaborators. Another important area is to increase transparency, such as registering trials, mandating results reporting, like I mentioned. And two really quick things I just wanted to talk about was in this domain of transparency. One is to actually share the clinical trial data. There are a number of reasons to share trial data. And the way we found to move forward here is to find common ground between academics and industry. If you had asked me 10 years ago, who would be the first group to share actual patient-level clinical trial data, I probably might not have said industry would lead the way, and academics would be laggards. But that's exactly what we found. We found, working with this wonderful partnership with Johnson & Johnson, they actually are making their clinical trial data available to us to share as part of this YODA project. So we established policies and procedures that are ensuring the interests of scientific investigators, the patients and the research subjects, the data holders. We started this partnership with J&J. We have a fancy website. And what happens is our YODA, Yale Open Data Access Project, our YODA project is sharing the patient-level data. People submit requests through the YODA team. We make a thumbs up or thumbs down decision about whether it's a legitimate scientific purpose. We're independent of J&J, and they've been giving the data. So we're just a trusted intermediary. There's a lot of cancer-related trials that have been requested, so please go to the YODA website if you want free, easy access to trial data. And finally, another example of collaboration with industry, because this is how we're going to get through this. These concerns about financial ties is not throwing stones at industry, but understanding ways to collaborate. Jen Miller has led the construction of this fantastic Good Pharma scorecard, multiple domains. She's focused on transparency. Reached out, partnered with CEOs and CMOs of all of these different companies, identified metrics for success. How do you count when you're making your data and results available? They use naming and shaming as their approach. Again, partnering with industry to give kudos to industries that are doing it well. And this is really nice. So more recently, this is their data sharing efforts. When they gave the companies their initial report card and then they gave them a chance to fix what they're doing, there's actually substantial improvement in some of these domains by working with industry. So I'm going to stop. I'm over time, but bottom line is find common ground, retain and nurture our concern about financial conflicts, and also we need to diversify and expand our funding sources for research. Sorry, that was a lot crammed in, but that's it.